is we're presenting. So hi everybody, I see you on the right hand side. This is a new experience. My name is Nick Van ter Hayden and I'm the orchestrator of this, and I'm going to try and weave our way through this to try and replicate our experiences. This is the first time we've done it. We've got 23 participants. I am looking at a screen over here to see what you guys are seeing, and I'm going to do a little bit of an introduction on how to use the controls first of all. You're currently all on mute, but I can unmute you all. I think if I unmuted everybody, it might be difficult, so we might do it as an individual process. And some of the instructions will help you understand how we engage and interact. I know this can be frustrating because you might be sitting there going, Nick, tell me this, or do this, or David, I want to know this. We're going to do our best through this, so bear with us as much as you can. My suggestion, if it's okay with the rest of you, that you see in the videos across the top, is I'll do a quick introduction on the way that webinar is done before you do your announcement, so that people have a little bit more control, if that's okay with you folks.
Absolutely.
Yeah. So I'm going to share my screen. Let's see, who can share? All panelists. Oh, that's not what I want to do. So, okay, so Microsoft, here we go. So I'm going to share this. Quick guide to Zoom, just to give people a sense of the controls. You should be seeing a full screen of my PowerPoint. And I want to give you a little bit of understanding. And again, I'm not sure exactly how you see it. I'm trying to sort of replicate it. But in the bottom of your window is a black controls, and you can force them to stay on. But they have functions that allow you to mute yourself. Right now, you're not. I'm controlling that, and also video, and we're going to explore that a little bit. If you've gone to full screen and that frustrates you, you can hit the escape button on your PC or laptop. It should bring you back to the regular display. And there is a gallery button in the top right-hand corner, or actually it's view options. If you go up to the top of the screen, and you can see there's some additional controls to allow you to change the way that things get displayed. Right now it's in the person that's talking. I'm going to try and shift that to gallery control. And then a little bit more about the menu bar: mute and unmute, stop and start your video, configuration for your audio. If you've got headphones, we can get a view of the participants. And important in this is that's the whole interaction. We have some Q&A at the side. I'm going to try and stay on top of that. I'm going to try and be in the background and just try and coordinate so that we get everybody involved. You can send messages privately and indeed, obviously, leave at the end of this. The participant list has a list of attendees. I'm going to look at that in a second to see how that's displaying. It also has the mute and unmute, and the raise and lower your hand is the key thing that you need to understand. That gives me an alert to say you'd like to speak. We are going to try and do the introductions as we do normally, so bear with us. That's the intro. I'm going to switch back at this point and allow Joe to take over whilst I look at things and see to make sure that things are displaying properly. Joe, over to you.
Great, thank you. And I'm going to hopefully, let's see. So we have some input for David. Can you move your camera down a bit? Maybe that's already happened. Okay, I'm going to go ahead and get, actually, I'm going to orient you to what's here, and then I'm going to pass things over to David to do his piece. So, okay, so good. So this is sort of at a high level who the main content speakers are going to be for today, and I'm really excited. The topic is there. One of the things that's new for Health TechNet is that we'll actually be able to see the content of the slides because we're not all sitting 20 feet away from them. So it'll be kind of a neat experience from that perspective. We do have, basically the speakers are going to get about 15 or 20 minutes to speak. And we're going to be, Nick already did his piece. We're going to switch to Jim and David in a moment. We're going to be wrapped up by 1:30. And so for those of you who have never attended a Health TechNet before, when we do them in person, they're on Capitol Hill, and they look roughly like this. In your cameras, you've got, in your views, you can see what the front of David Main looks like and the front of Jim Oakes. Here you can see the back. And you can also see there Linda Siegel is there and Simon is there. So with that, I'm going to stop sharing and I'm going to hand things over to David and Jim.
Well, let me be very brief, and then I want to turn it over to Jim, who really has spearheaded, along with Joe and Nick, putting this together. We all know that everybody's in a difficult personal situation. I myself am in Delaware, semi-quarantined with both my daughters and 4 grandchildren and another one on the way. We're doing our best, as everybody is, to live with the situation. Hopefully, the opportunity for us all to talk and to get together this way, will be an enjoyable experience. The last thing I'll point out is that by chance, this event has given us an opportunity to not only test electronic connections, which we've really never done before, but also to record our meetings. And this meeting will be able to be posted on our website for people who either want to see it again or people who haven't been able to participate. So many thanks to Jim and to Richard and to Joe and the other, and Nick, of course, for setting this up. Hope you enjoy it. And with that, Jim, I'll turn it over to you.
Well, thank you very much. First of all, I would say that before you all feel too sorry for David for being quarantined in Delaware, you should know that his house is on the beach. So it's not the worst place on the planet to be quarantined. So David, we do have sympathy for you, but only a limited amount. Before we get into the specifics of today's meeting, I do want to let you know that next month's meeting is still on track, although we may have to go to a virtual meeting again for that. We had intended to do that at the Chamber of Commerce, and I actually have a call that I'm trying to set up with them to talk about how to do that. They have moved all of their meetings to virtual meetings. In fact, they hosted a virtual happy hour yesterday afternoon, which I thought was a pretty intriguing idea. But the topic is set up, and that will be on venture capital and what venture capitalists are looking to invest in the health IT space. So we believe that'll be a pretty timely and interesting topic. So now, as Nick talked about this being an experiment, and of course it is, and we're going to experiment now with maintaining our normal tradition of having everybody in the room, with quotes around room, introduce themselves. I see that we now have about 35 participants. So Nick, let me turn that to you because I believe you have the ability to unmute people one at a time and let them introduce themselves, and just tell us who you are, what organization you're with, and maybe a sentence or a word about any particular things that you're going through with respect to the coronavirus or this quarantine that we're all living under or anything like that. And then we'll move into the program under Dr. Bormel's supervision. So Dr. Nick, over to you.
Thanks. And again, bear with us. I know this is frustrating. Linda, I do see your hand is up. Because we're going to go through the introductions, I'm going to offer you the opportunity. I have 2 ways of doing this, and I'm going to select the easiest from my perspective, which is I'm going to unmute everybody. And then I'm going to call you out because I see the list. I don't know what the order is. It looks like it's alphabetical, although Linda's at the top and that's not alpha. There are several people that have telephone numbers, and I'll call you out with the last 4 digits of your telephone number that you've used to dial in. Barry, I also see your hands up. if I could just ask you to sort of include this, if you could try and be brief. I know I probably haven't been, but I'm doing my best. I'm going to unmute everybody. That's everybody unmuted. And I'm going to call on Linda first of all. Linda Siegel. Oh, well, maybe that unmute all didn't work. Go ahead. I think I've got to do it individually. It says you're muted, although I've unmuted you. There we go. Linda? We can't hear you, unfortunately. Barry Lipsey, I have unmuted you.
Yes, hi. Quick question. I missed part of your introduction. I'm only seeing 6 of you. In other Zooms, I've been able to see all the panelists. Is there something that's different here?
That's a function of your screen size, as best as I can tell.
Okay.
So if you can expand or use the controls in the top right-hand corner that allow you to shrink it, then you'll see there are currently 6 presenters that you should be able to see.
Okay. Those are the only ones I was seeing. In others, I was able to see attendees. Okay. My name is Barry Lipsey. I do healthcare consulting, private consultant. I'm also a mentor in the state of Maryland venture mentoring service. I've got 2 ventures that I'm working with right now. And I love the fact that you've done this virtually. Thank you very much for setting it up.
Thank you. And here's what I'm doing. So Linda, I'm leaving everybody unmuted. I'm going to ask you if you could mute yourself. So I'm going to take the control away from me and allow you to try. I'm still going to try and coordinate. So once I've unmuted you, you're open. So that's just a warning. Make sure you mute yourself if you're doing anything we don't want to hear on this. So having had experiences of this, and I'm going through the list. So Brenda Blunt. You've muted yourself, but I have unmuted you. So there's 2 elements to this. I unmute you. You have to actually unmute yourself as well.
This is Brenda Blunt.
I've had to mute you, Brenda, because for some reason there's some feedback, and that's normally because you've got another connection that's in there. And there's the microphone is picking up the output from the other thing. So I'm not sure what's going on. I'll try and come back to you afterwards. I've left you muted for the time being. Richard, I can't hear you.
There we go. Yeah, to be more explicit about what Nick just said, if you're using audio on the phone and you're doing visual on the laptop, then you need on your laptop to hit the microphone button off, because that's the cause of the feedback.
Yeah, that's also an interesting point. Thank you for making that. But that also complicates this, because if that's what those 3 numbers are that are there, then that confuses me, because you're in twice and I don't know who those numbers tie up to. So hadn't thought about that, but okay, we're learning. This is all good experience, and it's recorded, so I can review it and see what we can learn from it. So I've got somebody that's listed as Kanabati. Forgive me if I mispronounce that. You're unmuted.
Can you hear me?
Yes.
Oh, good. Okay, this is Candace Abadi, and I am a consultant with Booz Allen, health consultant. And in terms of how this impacts me, I find it very difficult being away from my older children and trying to coordinate with them and make sure they're safe when they're far away. On the other hand, I'm having kind of a good time. My street is having a virtual cocktail party tonight. We'll all be on our front lawns. So that's my story.
Fantastic. Thank you. All right. Eleanor Fitall. You must. Yeah.
Hi there. Can you hear me?
Yes, we can.
Great. Hi, Eleanor Fitall, direct relation to Simon Fitall. I am a consultant at Impact International, focusing on healthcare quality and safety. So one of the things that we're thinking about at the moment is how do you keep the pressure on to maintain patient safety and all the other ways that we think about in this era of coronavirus and resources focused in different ways, particularly providers' time. So definitely a very interesting time for everyone.
Thank you. Erkan Hassan.
Can you hear me?
Yes.
Hi, it's Erkan Hassan. PharmD by training, independent consultant, leveraging telehealth to hospitals, health systems, and healthcare innovators.
Fantastic. Thank you. Joyce.
Yes, how are you?
Fantastic. We're getting better at this.
How I am doing well. I am sequestered in Germantown, Maryland, and all of my travel has been canceled, but my local travel, at least I don't have to get on the Beltway, has turned into conference calls. So although I am not leaving the house, I am still fairly busy.
Excellent. Thank you very much. Kevin McGrail.
Hello, everybody. Kevin McGrail, as you said. I'm with InfoShield. Thanks so much, guys, for setting this up. I love these meetings, and it's really awesome that it's virtual. My only comment I'll make is all I can think about, Nick, is max headroom with that virtual background for you. You held up a piece of paper, and I wanted to, yes, exactly. You held up a piece of paper, by the way, and it just goes to the virtual background. So
yes, no, I saw that. I was just going to say me too to being in Germantown. So but I realize that. Thank you.
Other than that, I'm letting my inner introvert child fly, and love the fact that I get to stay home and not feel guilty about it. So.
Thank you. Huey Zakusa, I think. Forgive me if I botched that. Or Hui Zakuskas. You're unmuted. You have to unmute yourself. Ah, yes, go ahead. Hui? Oh, okay, moving on, apologies. Kim Klein.
Hi, this is Kim Klein. I am with MedHealth Advisors, and I am so excited to be here because 8 years ago, we left the DC area and moved to Charlotte. And so I haven't been able to join since then. See a lot of familiar faces and hear a lot of familiar names. So I'm very happy to join. I am a health IT consultant, and I've done a lot of different things over the years, but the last probably 5 years or so have been focused more in the privacy and security realm, as well as working with HHS and ONC. So these are definitely interesting times right now. And I would say my biggest challenge is having my 8-year-old home with me while I'm trying to work from home. So we'll see how this goes. We have got e-learning set up, and so I'll be on my Zoom calls and he'll be on his Zoom calls all at the same time.
Fantastic. I'm just going to say I'm going to pull that as a silver lining from all of this. People that couldn't attend meetings before can now attend them. So that's one of my silver linings for today. Leo.
Hey, can you hear me, Nick?
Yes.
Okay, great. Hi. Yes, I'm also on my way to Delaware, and not too far, I don't think, from David. But other than that, been consulting and able to keep up with everything over the phone and Zoom and these wonderful technologies. I did invite 2 other people. I don't know if they've made it, but I'll take the liberty of mentioning. I invited Mark Wine, who, Jim, I forwarded some of his things to you, things that he's working on that might be of general interest.
Right.
And also my colleague, Stephen McCullum from Healthcare Innovations. You may be familiar with their publications and the seminars that they put on around the country. I'm working with Stephen on a series of panels on this very topic. We're hoping to get regional panels across the country to discuss what we think and hope will be lessons learned as opposed to current events in the healthcare emergency mobilization world. So that's just coming up, and we'll be working on that. I'll be very interested in talking to people who would have some interest, knowledge, or contacts in this field around the country on this subject. So I'll let it go with that, and talk to you later.
Fantastic. I see one of your guests.
That could be a great feature meeting.
Yeah. I see one of your guests, and we'll get to him as I get down the list.
Great.
And again, I'm just going in order as they show up on my screen. So if people wonder why you got bumped, I don't know what you see. Kathleen Dyer. Needing to unmute yourself. I've unmuted you.
Okay.
There you go. You're on.
Where's the video on this thing?
You don't. I don't have the video option.
Oh, okay. Okay.
I'm still exploring that. I would like to do that. Forgive us at this point. We just went with audio for the attendees, but hopefully we'll get to the video piece of it as well.
Okay, we're good. Thank you.
Okay. Lloyd Brodsky.
Hi. I'm a solution architect with Optum Government.
Thank you. Maggie Carey. Who needs to unmute herself. There you go.
There we go. Hi. Yeah, I don't even see my list, but I'm Maggie Carey or Margaret Carey. I'm in North Cleveland Park, enjoying the view, working on my garden. My work hasn't changed much. And in my neighborhood, between 6 and 6:30 today, we're going to go around the block waving at people from their porch.
I saw a few birthday parties like that.
So what I'm hoping to maybe play some music like Beatles, Stones, right from my front porch.
Absolutely.
Like they do in Italy.
Thank you. Adam Birnbaum or Birnbaum.
Hi, my name is Adam Birnbaum. I'm with Altruista Health. From a personal basis, of course, as with everybody, getting accustomed to being at home, especially when one of the people home is a teacher. So she's being hit by all sides as she's preparing to start doing remote learning, but then also a college-age daughter who didn't come home. So helping her get through that. Professionally, I'm accountable for a lot of what we're going to be discussing today for work staff in both the US and India. So balancing the different types of lockdowns, controls, and cultures has been fascinating.
Fantastic. Thank you.
Thank you.
Hamid Jalal.
Hi. Hi, everyone.
Go ahead.
We're doing the intro. I'm sorry I dialed in a little bit late.
Yes, so your opportunity to introduce yourself and a brief details on your background.
So I usually attend a meeting, I'm a medical officer with the Agency for Healthcare Research and Quality and with the federal government. So we pretty much are being told to telework unless we're required. And we have a task team that's looking at how to address Corona as well.
Fantastic, thank you. If you missed a little bit of the instructions, I'm leaving everybody open to talk once we go through this, and then you control your own mute, so just be warned of that. Monica Blaumella, I believe.
Hi, everybody. This is Richard. I actually invited Monica last night. She's a colleague of mine from many years ago. Go ahead, Monica. We know each other through the MIT Enterprise Forum in Washington, D.C.
Yes, exactly. Can you hear me now?
Yes, we can.
Okay, great. Thank you. Yes, I'm a business strategist. I gave a TED Talk on healthcare analytics and all the healthcare stuff I'm trying to do right now. Just everybody, all my contacts are they're so swamped with this emergency that they're just basically, they're incommunicado right now.
Fantastic. Thank you. Natalka Salbeji, forgive me.
Yes, good afternoon. Can you hear me?
Yes, I can.
Hi,
We
great.
can.
So thank you. Yeah, this is great that we're able to do this. So I have a background in digital health as a clinical technical expert, and just most recently was at the American Medical Association working on a clinical interoperability and a BP app for clinicians. And so just looking to see how we can all work together on this. So thank you.
Thank you very much. Phil Beenhauer.
Yep. Hello. Can you hear me?
Yes.
Hello, all. Great job emceeing, Nick. I'm Phil Beenhauer from the MITRE Corporation. I support CMS, HRSA, and now NIH in the areas of data analytics.
0.1 miles.
Ooh.
Turn left, and then turn right.
So, Leo, we can hear your instructions on the guidance.
You're almost there. You're almost there.
You'll have to mute. You'll have to mute me. I'm on a phone.
I hope you're not going into a red zone.
If it's helpful to you, I'm going to mute you, Leo. So
please do.
Sorry.
That's quite all right. I also started a graduate degree in social work at George Mason University last fall. So now I'm dealing with both Mason and Fairfax County for my kids, and now Health TechNet, as everyone tries to enact this distance learning. So I can't keep any of these straight. I don't know when I'm starting again. I don't know when my kids are starting again. And finally, if David Main can move his camera so that we could all see the beach, that'd be extremely helpful.
That's actually a great idea. Thank you. Thanks, Phil. Phil Cook.
Phil is having a problem with his microphone. He can hear, but he said he didn't have a dial-in.
He should be able to do it. Well, it's all in the invitations for those, and there's a few people I can't reconcile that because there are some numbers. I'll come back to those in a second if he's on one of those.
Yeah, there's an active chat conversation going on with Margaret, and I put out a challenge to all panelists. So Phil made a note that he can't speak.
So forgive me, I'm not looking at the chat right now because I'm trying to concentrate on the introductions. I'll get to it when we get to the presentation. I'm trying to get through this. So my apologies if I haven't responded to anything. Ray Scuzdalo.
Hi, it's Ray Scudlow. Thank you.
Thank you.
I am the general counsel at Be Well Connected Health. It's a platform for aggregating your healthcare information across multiple platforms. We have been, I'm pleased to announce we completed our Series A round, raising $16 million from Theta Care, Unity Point, and Walgreens.
Congrats.
We are, we're doing quite well. We've moved to a virtual meeting and closed our office temporarily. And that so far has worked out pretty well.
Fantastic.
On the personal side, we are having quarantine parties. And the music that we play is the Stones. You can't always get what you want.
Absolutely. Thank you.
And I'm my logistical challenge right now is I have a grandson due to be born middle of April. So we're hoping that things stabilize before then.
Wow, good luck with that. So I do know this is a lunch meeting. I don't want to call you out specifically, but I can see who it is that is eating. And I just want to remind everybody that they should mute themselves because I'm not, once you've talked, you're on unmute, permanent unmute. So just be a reminder. We can hear you munching away at, I'm just going to say probably chips, potato chips. That's my guess. So,
and Nick, as a time check, just pointing out that it's now 12:31. I think this is good to get everyone involved, but I also know that we want to get all the speakers have a chance to have their time slots.
I would be guided by you. I'm not sure how to, I've got 1, 2, 3, probably 7 or 8 more people.
Let's go do the 7 or 8 more people, recognizing that we're a little over time.
Okay, so all right, we'll speed it up. Apologies to those at the end. Roger Maduro.
I'm Roger Maduro. I'm the editor of Open Health News, and this is a huge
area for us. We've got over 1,000 posts in Open Health News on the use of open source software, particularly third world countries, for disaster response and pandemic response. Very successful for pandemic response. And maybe later I can add a couple of things. There are 9 countries around the world that have contained the coronavirus. And I've kind of been following them very closely. And later on, I can kind of outline what they did.
Okay. Well, thank you. We'll leave that to the Q&A at the end. Ryan Whelan.
Hi. Yeah, my name is Ryan Whalen. I'm a cybersecurity engineer with InfraShield, specializing in critical infrastructure. And I'm a guest and co-worker of Kevin McGrail.
Thank you. Daryl Roberts. No. Okay, I'm going to move on quickly. Sanjeev Desai.
Yes, hi, can you hear me?
Yes.
Yep. Yeah, hi, Sanjeev Desai. I work as a physician informaticist at Northrop Grumman. We work with CMS, CDC, Department of Health and military. My team, we're involved with developing predictive analytics models for different disease states, and now we're trying to focus on COVID-19.
Thank you. Seth Rubenstein. Not coming. Stephen McCollum. Nope. Okay. Steve Kubersen.
This is Seth Rubenstein. Can you hear me now?
Yes, Seth, we can hear you.
All right, when Steve comes back on, I'm a podiatrist practicing in Reston, Virginia. I am the incoming president of the American Podiatric Medical Association. Technically, I should be president, but we canceled our House of Delegates last weekend, so I'm in hold mode. I'm part of a very big group practice, about 77 doctors across 5 states, and we are walking a very fine line right now between seeing patients to try and keep them out of the emergency rooms and closing our offices down. It's going to be day to day.
Thank you. Good luck. Taylor Devine. Nope. And then the last person I have, aside from the phone numbers, is Tom Bascom.
I wrote up a brief summary of what I wanted to talk to everybody about and put it in the chat section. So if you haven't opened the chat section, please do that and look at my message. I need help. I think I got a way to help the top to bottom government communicate on the coronavirus message, and the right channel to do it. And I'm trying to make it happen at a speed that helps really, get the message out.
Fantastic. That gives me an excellent idea. For those folks that don't get to make a point or would like to, please put it in the chat. I will store the chat, share it with David, and I think we'll circulate it because it's useful information. Apologies if I don't keep up. It looks like I've got a lot of messages to respond to. I'm going to hand over to Joe, who is going to take the baton, and I'll try and stay on top of what's going on here. So thanks, everybody.
Yeah, that was very, very helpful. Thank you, Nick. And I've got, so let's see, screen share. Very good and excellent. Yeah, so it's 12:36. I will try to keep us on a bit of schedule here, which is, so I need to wrap up around 12:55 for you, Simon. Okay, so I was chatting with a friend who was a senior VP at Cerner until he retired a year ago. We're talking about the COVID, a lot of technology issues, and he said that he remains a technology optimist, and that the example he gave was that the Chinese were able to sequence the COVID-19 virus in 1 week. Obviously, in prior pandemics, that would be somewhat incredible. The take-home messages for my little section here is, you can probably read it faster than I can say it. We did want to just talk, cover some information technology at a high level. The second point is that the information technology to surface one local death equates to recognizing 100 people who are, infected in that location, or up to, to higher numbers, which could be temporary local lethal spreaders. So the issue of being able to find and communicate one death, and then recognize going backward what must have taken place over the last 2 weeks or so for that person to have died, tells us a lot about the community. It's a lot of information in what otherwise could seem like just an anecdotal piece of information. The third take-home message is that data collection in life and healthcare is incredibly important, important to public health, and is both unsolved, and through this crisis, it's become even more clear what the challenges are with which we know. And this is not a lecture on COVID, just cover some of the health IT issues. And the last take-home message is that health IT applied as telework and telehealth and teleplay are all essential white knights. They're just technologies. They're applications or visualizations. They're using the cloud. They're making things possible that weren't possible. But what they're enabling is expression of healthcare in the form of one-on-ones between people to facilitate coaching, facilitate feedback, and that's really what the health IT is about. I'll recognize that, but I wanted to call that out as a important take-home message. And that whole issue of being able to go one-on-one, there was a wonderful telemedicine webinar yesterday done by the ATA and Fitall. Some of you may have seen, and I may have mispronounced, but they they really made the point that in this age of COVID, being able to do virtual visits or being able to see patients virtually in a room without having to go in the room in more intense settings is something we've been able to do for a long time, and now we really have to do it. So I'll just take it from there. So my qualifications to speak are that I have a Hopkins degree in engineering and computer science, University of Maryland degree in medicine. I'm internal medicine boarded, and I'm rheumatology trained at UCLA. And I've got a Harvard degree in public health and informatics, along with a tremendous amount of industry training. As somewhat of a humorous piece only for people in the room, what is becoming real as more medicine is to have a wall of diplomas that is nearby and in the background. And if, Tom, if you'll stop making noise, there we go, thank you. So you can see the diplomas I just made reference to. And if you have a chuckle, then I've had the result I'm looking for. The work experience, I've been a, Nick, can you mute Tom? It's disabling my—
Sorry, I thought I was muted.
Yeah, sorry. I have a live monitor, so I can see you're all seeing as well.
Can you hear me now?
Yes.
I don't have a mute control button on my menu here, so I can't mute it.
Maybe Nick can handle that. So and relative to the people who introduced themselves, that was really quite wonderful. I've been a mid-level executive at Cerner. I've been a senior executive at Quadramed. Both were publicly traded $100+ million vendors. That are now both part of billion-dollar corporations. The Quadramed was sold to Nuance, as well as some other entities. I've been a medical officer at the HHS and ONC. I've done a detail at AHRQ. I've seen the process of how proposals are reviewed, as well as looking at some of the just amazing content that's been developed in that space, and then the sort of the marketing and knowledge transfer challenges that ARC have are really They're both good problems to have, but they're frustrating problems. And I've done a lot of contracting. I've done biosurveillance work for SAMHSA, CDC, FDA. I've written quality measures under contract for CMS. I've done digital therapeutics strategy work for the United States Pharmacopoeia. And I'm currently doing two really incredible projects from my perspective, incredibly important and interesting. We are bringing forward the measure authoring tool that CMS uses for electronic clinical measures and bringing it forward to use FHIR resources, FHIR quality measurement resource, as well as to be compatible with and take advantage of all of the things on FHIR, MAT on FHIR, CDS on FHIR, CPGs on FHIR, just a lot of reuse of those resources, which is really what a big part of what the whole FHIR movement is about. The other major contract I'm working on, we're a prime contractor to NIH, developing a dynamic e-care plan focused on how to support multiple chronic conditions and with a lead of chronic kidney disease, all using FHIR, all doing implementation guides, and doing this in concert with work for social determinants of health, Evelyn Gallego and others in that space, and so harmonized to the HL7 Gravity project. So my experience is relevant to the issue of biosurveillance and improvement of the quality of care delivery. And lastly, I realized that it's kind of anemic to talk about someone's experience without calling out, your personal life situations as they relate to healthcare delivery and the complexity therein. So I'm in a sandwich generation. I've got my two parents living with us. One is using memory care. So we're essentially running an assisted living facility. I've got significant experience with chronic disease. I would qualify both by age and by another condition to be in a high-risk group with the current coronavirus. So that's humbling. I've got more experience than I'd like to have with mental health issues. My sister had a psychotic mental health disorder and committed suicide. So I have a tremendous amount of understanding and appreciation for that space. And I've had a lot of experience with cancer. My best friend died of cancer, and I was with him through the whole process. My dad died of pancreatic cancer. I know we've all had these kind of experiences. I currently have half a dozen friends who are roughly my age who are in chemotherapy. So really pretty crazy thing. The photo there is me in a kayak, and it's for me to remind you that I come from Baltimore. In the background behind me is Fort McHenry, where the Star Spangled Banner was written, and I'm part of a meetup group that does a kayaking tour, so that's me in the Baltimore Harbor. So I like to start my talks out by saying that I really believe in the scientific method, randomized trials are really great. When I got my children, 18 and 19 years ago, I decided to treat one as the treatment group, where we used safety measures like the helmet you're seeing, and generally using all the best practices. And then we used my son as a control, and without those things, to see how things would go. And so I can tell you now, roughly 15 years later, the entire family is wearing helmets and even harnesses. And so what I've learned from science is that we need more interventions. But what I wanted to cover today was the main topic is to orient the audience to the Johns Hopkins Coronavirus Global Health Board. Most of you, I'm sure many of you, at least half of you, have seen it. There's things about it that you probably haven't seen, and I'm just going to walk through it very quickly. I've created a short URL for those of you who want to go there now while I'm talking or get back to it later. I made a short URL automatically that was random, and it was really, really hard to memorize and very easy to get wrong. So I made one with my last name. And so you can see that there. And then I'll talk about the ABCs of biosurveillance and stay on schedule. One of the things that's interesting about the Johns Hopkins COVID-19 dashboard is one of the most widely used dashboards for COVID. The screen that you're seeing there is actually from about a month ago, but at that point in time, they were getting 1.2 billion requests per day. That's billion with a B. Almost all the data from China comes into it automatically. Almost all the data from the counties in the United States where the data is coming, it's coming at that level. Almost all that is coming through manual data capture. So it kind of gives you from a health IT perspective, kind of a broader perspective on this. Thank you for putting that link out, Nick, so people can just click on it. And one of the points they make when they show this slide is that they can see that the interest, it's in terms of the usage of the site based on events that are described in there. So this is what the dashboard looks like. I'll hit the obvious thing you haven't seen before that's you're not going to see on the web page. On the right-hand side, you see Dr. Gardner. She's the person that she and a team of two postdocs were the ones who brought this system up and are keeping it up with some very notable, impressive partners, including the I want to say ERSI folks. But just basically to orient you to what you're seeing here, this is from today, from a little over an hour ago. What they're showing is in the top left-hand corner, 250 or 250,000 total confirmed cases worldwide. If you go down to the bottom right-hand corner, you can see a circle, and you can see that, and this came up in the comments earlier in the call, that mainland China is having no real growth in the number of cases. And certainly other countries have taken procedures, fever clinics, isolation, heavily using hospitals, and certainly quarantining in place. They've been able to get those kind of results. You can see the total deaths are the highest now for Italy, under the 10,000 total deaths for the virus so far. You can see that 3,000, or obviously a third, are in Italy, which exceeds China, and they've had it for less time. And you can see the other death rates in there, and fortunately, the United States is not in the top list there. For those of you who are going to either click later or don't have a chance to click, pretty much everything on here you can click and it's active. So you can click on the countries on the left and it will give you a view of that country and a breakdown within that country, kind of a Pareto that's specific. You can change the view from cumulative confirmed cases, which is going to just keep getting larger, to active cases, which removes the total deaths and the total recovered cases. So it's people with active disease right now. So really, really, really powerful summary. If you were to go and blow up that bottom right-hand corner, you'd see this picture, which I kind of talked you through, and you can see the other location is the yellow bar that continues to go up and is now getting to about 160,000 cases. You can also switch to looking at daily cases. The one that really is the last full 24-hour period is that largest peak there that's hitting 28,000 new confirmed cases yesterday. So that's how to read that. By the way, my slides are available. If you send me an email, we'll have them on the site. But so this is slide 13. And what you're seeing here is, this was from roughly a week ago. So you can see the total number of cases a week ago was half of what it is now. And the total number of deaths also similarly about half. So we've seen a doubling in the last week from March 12th to today, March 20th. Here you're seeing what things looked like in February 9th. So we only had 40,000 cases as compared to the 250,000 we have today, and only 814 deaths, and you can see they were all in China, and you can see all the curves, et cetera, reflecting that. So what's going on in the United States? If you click on the United States on the left-hand column, and I did this again within the last hour, you can see that there's 205 total deaths in the U.S. right now. The largest single amount is 74 deaths in Washington State. The next biggest number is 38 deaths in New York. For those of you who are news junkies like me, there was a wonderful Daily Show interview with Mario Cuomo about the death and the management of death in New York 2 days ago, and it's just really incredibly sobering. 18 deaths in California, and you can kind of read on from there. And then if you actually zoom in on any city and click on it, you'll get a state view. And again, this is from within the last hour. Maryland had 107 cases and 1 death, 106 active cases based on the nature of our current surveillance. I'm sure most people on the phone know that, whether the multiple of active cases right now is 10 times that or 100 times that. We don't. It's speculation. There's ways to justify a guess, but they're just guesses. There are 2 deaths in Virginia, as of basically now, 105 cases, and in DC, you can see the numbers there and no deaths. What I did here was I just gave you a successive picture from February 9th at the 37,000 deaths that you've seen, from 2 days ago with 200,000 deaths, and from today, from this morning, 250,000 confirmed cases with 10,000 deaths. So it's just kind of a really powerful way to take the numbers, which individually are very, very difficult for any of us to make any sense of. So I'm looking at the time. I want to make sure I leave lots of time for Simon and for Richard. So for those of you who are not doctors, Bible, or a humorous sort of a mad magazine for medical students called House of God. It's a book. And one of the laws in the book is if you don't take a temperature, you can't find a fever. And it's kind of the cynical aspect that if you don't want to find a fever, then don't take a temperature. And in many ways, that's kind of why the reporting in the U.S. It's more complicated than that, but part of why we aren't taking temperatures, it's not necessarily we don't want to, is that we haven't had the tests. We haven't had the clarity until the last couple of weeks about what was really at stake, and kind of a realization of timelines that we are kind of lacking on seeing all of this. I think one of the most important things to look at think about when you look at that global case board is kind of what's the y-axis? What are they actually looking at? And as you could see from our whole discussion, it was about active cases, and of course how that translates into death. And so and the reason why you pick something to focus on is you pick something that is a lever for you, that if you can impact it, you're going to have an outcome impact. And so everyone has seen the flattening of the curve, but I just calling out the connection between the y-axis here, the number of cases, and the entire focus of that COVID dashboard, which is all about number of cases. And we already had a discussion earlier in this call that, and we'll have it again in the review, that 1 case of death now means that there was at least 100 people who were impacted within a geographic locality of likely of that case, and there's been 2 weeks for that to spread in that area. So 1 death is actually a marker of something much bigger and important to notice. I drilled in here just to show the Washington D.C. area. As of a week ago, it's about the same right now in terms of cases that are showing up on their board. I mentioned earlier that there's a view that shows active cases, so it takes away the deaths and total recovered, and that's what this view is, and these beige pieces. There's some other dashboards out there that are really quite amazing, and they as opposed to looking at total number of cases, they often look at some other things as well in addition to cases. So this tracker is the only other one I'm going to show you today. they showed the total number of confirmed cases they were showing earlier today was about the same as the Hopkins tracker. They were showing 250, and this is showing 242. Tracker was at 244 this morning at 6 a.m. They were also showing death by 100 infections, so 4.07. That number actually has been going up over the last weeks on this tracker, and it reflects a bunch of things. You can also see confirmed cases by country, excluding China, and you can see Italy has just exploded. And then some of the countries that people were mentioning earlier in the call that have really kept things under control. They also, they shift over time, but this website also focuses on showing other interventions and doing it kind of geospatially. So what they're showing here is a number of schools closed, a number of schools impacted by state, essentially over the last week to 10 days. So really fascinating. And then in terms of optimism and hope and excitement, we also move on to the clinical trials. They give you links to where the various clinical trials are and what phases. You can go back and see the NCT numbers for those trials. You can drill down and see what's going on in the trials and what they're looking at, what the status is. So absolutely, really, really powerful. So that's a quick view of the Hopkins case board. We'll take questions at the very end if that's helpful. I just want to orient you to what else is in the slides. And again, we can talk about it later or some other times. But I wanted to make the point as both a physician and a public health person and a person who apparently has diplomas next to him, that's this issue of picking what's the most important number and then what we can drive influence is a really, really important question that we didn't do enough of even before COVID. And so, as was mentioned earlier, there's actions that were taken in the pandemic in terms of increasing the amount of fever clinics that were being done, as well as the protocol to not let people go back to their families who had a fever, the COVID virus testing, the availability of both antibody testing as well as antibodies to be used as a serum for people who have the infection are things that are measures that will become more prominent. There's something called a cytokine storm, which seems to be a tremendous activation of the immune system, inflammatory system, that's associated with people who die from this infection. And there's various measures for that are very well known to physicians. And then we already talked about flattening the curve. I wanted to point out that, and again, I'm looking at the time, that the two of the biggest public health issues that are more chronic issues are hypertension and diabetes or blood sugar. And there's data processes for screening, sampling, and management that are woefully underused in 2020. And there's reasons for that. A friend of mine who has an insulin pump said diabetes for 20 years now. I asked him about what his glycohemoglobins were, and he looked at me and he laughed and he said, that's like the most irrelevant, this wasn't recent, most irrelevant thing in the world, because glycohemoglobins are, an estimate of an average of how you were doing on glucose. But with a continuous glucose monitor, down to less than a minute exactly what your glucoses have actually been. And so a lot of the kind of things we did in screening and sampling in the past and their quality measures are really dated. Nobody's fault, that's kind of how things go. So within this, kind of a breakdown of assessment, behavior, and cumulative impact that one needs to think about in terms of picking measures. And then a kind of a nod to my friends at the AHRQ. This work was funded by them, and it's absolutely fantastic. Essentially, the kind of measures that are really important nationally are summarized here, and I'm glad we're on the WebEx or Zoom because you can actually read all of it. I'm going to zoom in on the hypertension, just to kind of give you where the baseline is, and back 7 years ago that it was about 50% of people with hypertension were being screened, and there was a goal to kind of get that up, along with meaningful use in other measures. It's certainly better, but what we learned 5 years after this work was done, and again, ARC led this through their National Quality Strategy and Disparities work, is probably no surprise if you're Caucasian and affluent, you've done better in terms of improvement. And that's kind of disappointing that we're not doing better than that. I'll let Nick talk about continuous glucose monitoring if we have time at the end. In non-diabetics, it's phenomenally important. Again, for your reference in the slides, not only is there, if you don't take a temperature, you can't find a fever, but if you don't take lots of blood pressures, you can't treat hypertension, and we generally don't. If you don't continuously measure glucose, you won't know what oatmeal does to you. And thank you, Maggie, for pointing out the work of non-diabetics using glucose monitors and the significance of that. And the work I did for the Substance Abuse and Mental Health Services Administration for the opioid crisis, most emergency rooms, if they don't have a reason, at least historically over the last 4 years, if they didn't have a reason to do or a suspicion to do a urine tox screen, they wouldn't do one. And there's other reasons to not do it. So in summary, the take-home messages are that health information technology is clearly essential. One local death is a critical harbinger. Data collection is non-trivial and it's to chronic diseases. And health IT is a white knight, but expectation management is critical. It's very, very easy to get people very, very, very upset that if you're not keeping up with a crisis, and it may not be possible. And we can talk about that at some other time. So I sort of started off with my family and my scientific experiment. And the big recent accomplishment is we got my daughter through high school. So this was our graduation picture. So with that, I'm going to relinquish the screen. And let's see, figure out how to do that. Undo the, stop sharing. And I'm going to hand things over to Simon.
Thanks very much indeed. I'm assuming that this is working. And I'm going to share my screen. We'll take a 5-second pause to do two things. One, enjoy the view. And secondly, can everyone who's not talking, please mute their microphones? There's a bit of background noise. I'm going to jump straight in. I did two things on this one. I promised Joe that I would do a technology-based technology presentation. So I'm using a piece of software called The Brain, which I won't go into, but I start off by showing you this is the latest version of the, so 255,000 is where we're up to. You know, that's where we are with regard to what we need to talk about. What I want to talk about is the issues related to chronic care in a pandemic. The adherence and compliance is essential for high-risk populations. Basically, we know that the older people with chronic conditions, particularly respiratory-related, but also diabetes and the usual crowd, their existing conditions need to be well managed in order to potentially move them to a slightly lower, higher risk, if I can call it that. And the provider staff are becoming overwhelmed with caseloads. We're seeing stories of this all the time. Of course, it goes without saying that this picture here is the one that's been drawing everyone's attention. This is a piece from the Imperial College paper that was published earlier this week that got everybody's attention, because it essentially said in quite scary language, if we don't get it right, we're looking at a couple of million deaths in the United States. And if we do get it right, we still might be looking at 1 million. So that was kind of, okay, let's pay attention. What we're looking at here is a solution that we're about to pilot. We're going to be starting this pilot next week. And it's all about targeted outreach. The principle being that medication history can very quickly help us to identify patients who are not compliant or adherent with their chronic medications. We already have Medicare billing codes and a number of other private insurance codes that allow for enabling trained call center personnel to call patients to assist with those care plans. And so what we're looking at doing is applying that existing technology, that existing billing capability, to help to troubleshoot medication issues in these high-risk populations in the current pandemic. Stage one of this process is to go into patient screening. I'll bring this up full size so everyone can read it. There are essentially three levels we do it. One is most practices that are involved in care management have already got a list of their high-risk patients, and so we can use that as a start point. The second stage is that we access into the EMR, whether that's through direct API access or FHIR access. It is entirely dependent on the technology that's available with the practice. And we do some fairly conventional screening of records to identify higher risk patients, but that can then become an ongoing process as opposed to the existing list, which of course is fixed. And then as a third step, we can get into more sophisticated EMR data screening, which is looking at a much wider range of contributory factors. But initially, we're going to be doing phases 1 and 2. The next step in this process that we're putting in place is the retrieval of medical history. The first stage is that we get patient details together, which is essentially their name, date of birth, their zip code, their physicians, their names and zip code. And what we're able to do is access the SureScripts system effectively in real time. And that covers approximately 83% of the population, about 92% of all pharmacy claims. And what we're able to do is to access and download full details of all filled prescriptions. This is highly current data. It's basically it's current as of yesterday. That's the worst case. And what we're then able to do is to analyze that data set to identify patients who are at risk. Are they compliant and adherent with their medications? What medications are they on? Because from the medications, we can get a very clear view of what their comorbidities are. And so we can identify those patients who either aren't coherent, compliant, not coherent, not compliant or adherent, patients who have a script that's about to need to be filled, these sorts of activities, which are of course normal activities for the call center staff. This is the sort of thing that they already do. The call center staff already exist. They are nurse practitioners or physician assistants. Using number masking, we're able to call the target patient and carry out the care management program, whether it be medication planning, triaging to additional services, and of course in this situation, educational and support information with regard to COVID-19. Once that's all completed, we're then able to use the existing codes to submit the billing claim for that activity. Now, the benefits of this are fairly straightforward, and they are exactly what you'd expect them to be. Improved outcomes, education, improved patient experience, all things that we're aiming to achieve under any circumstance. But in this instance, we're able to do it because we take on the responsibility for the care management program. We're able to do this without adding to the costs at the provider level. And the most important part of that is that we're actually reducing the workload at the clinic level, whilst at the same time increasing their capacity to contact patients. So in other words, we become a force multiplier. And that basically is what we're doing. Now, there are a number of other things that I can show, but I did want to make sure that I went through it fairly quickly so that we had the opportunity to look in more depth. And I thought that probably one of the things that you might want to see, oh, sorry, I just hit the wrong button. Hit this button instead. The mechanism by which we do this is through a direct connection to the SureScripts system. And so not only do we get the pharmacy record data, we also get the pharmacy benefit management data as well. So there are other things that we can do on top of this straightforward care management in pandemic environment. But I didn't want to go into all of that in huge depth and detail, unless, of course, there are questions. And of course, we're more than happy to talk about other questions later on. And the easiest way to get me is there. So I'm assuming that we're doing questions later, unless there's something that anyone wants to particularly touch on immediately. I'll leave that to Nick.
It's probably best to let Richard get started.
Absolutely, that's what I was thinking. So I'm going to stop sharing at that point. Thank you very much indeed. And I'm now muted.
I'm just going to say, Wilco, Danny boy, thanks.
Yeah.
I think, Richard, it's over to you. You've got to unmute.
So I am unmuted. So great. Speaker view. Just 1 second. Great. Get rid of the enter full screen, exit full screen. Okay, so people can all see me. Great. And can people see me? Hello?
We can see you, but we're not seeing your screen.
Oh, I'm not sharing it just yet.
Oh, okay.
Give me 1 minute.
Yeah. All right.
Okay, great. Wonderful. So on that note, great. So hi, everybody. So this is Dr. Richard Singerman. I'm really excited to be giving you a quick, I think I only have about 15 minutes today, presentation on some of the things that my master's students had done in a class about a year and a half ago related to informatics innovation. Real quick about me and my perspective. I did my postdoc at the NIH doing a simulation of actually next generation MRI devices. That's kind of my perspective originally as a physicist, and then moving into healthcare and health technology and technology commercialization. Really soon after that, I went and worked with Ascension Health for 3 years, which is the nation's largest Catholic hospital system, largest nonprofit, about a $15 billion health system, where they give away actually about $1 billion of that in charity care every year. But Ascension has 15,000 beds across 20 states. Really wonderful to work with. And then I was with actually the first office of the national coordinator with Dr. Brailer, working on initiatives around clinical decision support, and most importantly around measuring the adoption rate of health IT. Then after that, I worked with IBM in their translational medicine initiatives, working with academic medical centers and the military health system on their innovation informatics strategy. And then finally, bringing us up to present, I've been with TrustNetMD and Prosperata, TrustNetMD. We work at sharing, at knowledge sharing for community and public health. We actually won funding from ARC, and the work you're going to see today is based on that work that was originally done for knowledge sharing for clinicians, for community healthcare workers and social workers to share basically evidence-based resources and knowledge on the ground for social determinants of health. And then we took that platform and then we moved it, and actually were able to use it also for teaching this course. It was a master's level course that was sponsored by Kaiser Permanente, run through Loyola Marymount University, where Kaiser was really trying to come to a perspective of doing much more systems engineering approach to healthcare. So half the courses were taught by physicians around patient safety. The other half of the courses were taught by folks such as yours truly, affiliated with Loyola Marymount on the West Coast. Loyola Marymount has actually a rich history of serving the aerospace industry in LA. And it's kind of interesting for this nice Jewish boy to be affiliated with both not only Ascension Health, but also Loyola Marymount as the Catholic one. So the Catholics keep on working on me. They haven't succeeded yet, but over time, I'm sure they think they will. So on that note, I will start screen sharing. Now I'm actually gonna be running through a live demo. I did do screen captures of all this, so it's available as slides afterwards, but I think it's more fun to run the app as a live demo. But if anything hangs up with there, we have the photos as a backup. So I'm going to do screen share. Wonderful. And I'm going to pull up just first, I'm going to pull up this. Great. So this is, oh, I've got way too many pictures here. Oh, by the way, I was going to mention, by the way, if folks are having trouble seeing the whole screen, if you pull your arrow over the box as people's pictures, in the upper left-hand corner, there's like a 9-dotted grid. There's 2 horizontal lines. There's kind of a blob and then a single line. So if you press those, you can play with making this making that part of the screen smaller so you can see more of the presentation. So I'm going to minimize that myself. Let's see, move that over. Great. So, and I just want to minimize these pictures of everybody there. Okay, great. So this is what you're looking at is a, oops, sorry about that, is a presentation that this work was based on out of Hopkins. It was done with Harold Lehman, who's the head of research informatics there. Chris Gibbons is now the chief health information officer over at the FCC. He used to be head of the Urban Health Institute over at Hopkins. Steve King was our programmer. Joe Warren worked with Harold Lehman's group. And John May is a co-founder of mine with TrustNetMD. And so with that, let me just take you to live. So just let me make this smaller. Sorry there. Just 1 second. Okay, so great. So this is the site, and I'm going to bring this up to full screen. There we go. Great. So there's a little note here. It says your screen is sharing and paused, but I guess you don't see that. So that's fine. Great. So here's our site, Community Healthcare Works. And what we did is we really focused on the workflow of the community healthcare worker, the social worker. We ran focus groups, about a dozen focus groups with about 5 to 10 community healthcare workers or social workers.
Richard, we're still seeing your poster. We're still seeing your poster.
That's interesting. You should be seeing the site. Your screen sharing is paused. Resume share. Okay. Resume share. I'm going to close that. Now, Joe, can you see the, whoops, screen sharing is stopped as a shared window is closed. Just 1 second. Okay. Screen share again. Okay, how's that? Joe, can you see the website now?
Yes.
Wonderful. Okay, thank you because I can't, I was actually looking at different things. Great, so now that works, great. Okay, so so this is the site. It's both a mobile app and available as just a normal website. So this is Community Health Works. And what we did is we organized this site, basically the information architecture around the workflow of the community healthcare worker, the social worker, and essentially it works for the family caregiver too. We asked them what their day was like, what their challenges were, and then basically all their work kind of fell into kind of 4 big buckets: assess the client's needs, connect them to community services, address challenges and barriers for meeting those needs, getting them to their services. So if they have to get to the doctor, but they can't get transportation, that kind of thing. And also support for the caregiver themselves. And the whole idea of this site was, on one hand, we did a large scan across areas what are diabetes, cancer care, suicide prevention for various populations, veterans, women in disparity communities, et cetera. And you'll see that kind of grid in a minute. And then, we actually, through partnership with the Hopkins Library, did a large scan of resources around each of those different areas. So it would be a set of resources that were available in the language of social workers, community healthcare workers, turns out public health workers, very much that kind of language level, not assuming the level of a nurse or a doc. So I think it's really important when you're organizing this kind of information to have resources that are digestible, but also have a way to navigate those resources in a way that's amenable to the population that you're working with. Okay, so that was assess, connect, challenges and support, and of course, and that's the same that you get on every screen: assess, connect, barriers, support, and then the ability to ask questions of each other and to post answers. And that was it. But it actually turned out to be a very rich set of capabilities to do all that. So if I go to assess, well, that sounded like a ship's whistle. So Joe, can you see this next window okay? The assess window with this kind of grid?
Yes.
Wonderful. Okay, I'm going to do these little checks every couple of minutes to make sure we're okay. So wonderful. So we had the health situation, behavioral health care, the work situation, the disability, the populations, the client strengths, the client profiles. So for here, we actually had a wonderful amount of information on, so if I just hit like infectious disease, then that button that comes up in a search, and I could do multiple terms, but just on that right there, we had we had this wonderful set of resources. In the same way, so you could go back again, and you could also do, let me just scroll a little bit here for you. We also have communicable infection, so similar type of thing. And so what we did is that we used this site of being able to post questions and answers, kind of like almost a Reddit, if you will, and then we used it for teaching. So here we had a module of the week. So here was the course name, the week of the course, week 10, public health, and getting into more of the things like these are different tags: communicable infection, functional requirements, disaster medicine. And this was the topic of the week. And students had to basically look at this every week. And so we said, what are your thoughts on the following article: improving health preparedness, strengthening biosurveillance systems for enhanced situational awareness. So students would click on this once a week, and here's their module of the week. And so I would describe, I'll make this a little bigger for folks. Did that blow up on your screen when I did that here?
Yes, it looks great. Wonderful.
So to really be able to see this nicely, so the students say, okay, what are your thoughts on this week's article? Here was a main, let's say, picture from the article, and I'm gonna get into that in a minute. And then I'd say to students, okay, well, see this article on page 23, which shows the information flow cycle. And we talked a lot about that in the class. Like, how do you go when you look at everyone had to be responsible for a final project where they looked at a patient experience, whether it was for cancer care or genomic testing or for elderly care, that kind of thing. And throughout that patient experience, they would have to look at, well, whether they were education, showing symptoms, getting diagnosis, treatment, recovery, throughout that patient experience, or the customer experience chain, or what you might map out if you were doing design thinking around the patient experience or ethnographic studies of the patient. You'd say for each of those parts of the chain, say, how do they acquire information, analyze, store, distribute information, make decisions on that information, and measure the value. So students had to do all that and think about that. And there was an analogy to this surveillance situational awareness as well. So students would, let's say, so they'd go to the resource and they'd click on it. And so I just downloaded this report. It's actually a really nice report, by the way, 2013, but it has, improving public health preparedness. It was funded by CDC. It was run by University of North Carolina. But you'll see it was involved a lot of the people that are involved in this disaster today. The Florida Health Department, Boston Public Health Commission, folks from the CDC, Georgia Health Department. So this was really a really nice multiple group of folks. So if I exit out of that, oh, I'm sorry. Just one second.
And while you're doing that, just a time check, it's about 1:25, and we do need a few minutes to wrap at the end.
Okay, all right. So if I just pick that one up, and go to full screen back on. Go on this, I don't need to go full screen. So on that paper, let me pull that up again, I'm sorry. Let me just give you an example there. I'll just pull it up. It downloaded it right here. So I'll just pull it right there. So yeah, so just to spend a couple of minutes on what they did here. So this was really a really nice, see if I do full screen here, thing that's worth a minute thinking about, because this really shows what we're talking about. So students had to look at the collect, manage, analyze, interpret, and report, or what we call the acquire, store,
I don't
analyze.
think we're seeing whatever you're seeing.
Oh.
Still on the old screen with the page CH resources.
Okay, let me just go back to the browser then, sorry. All right, I'll just go back to here. So now we're back on this, I must be on the same one as you. Do you see it moving up and down?
Yes.
Okay, good, so fine, we'll just do it off that screen. This one's not quite the resolution, but as I was gonna show the other one, but I'm not gonna worry about it. So, you know, you interact with government agencies for ASPR, so Assistant Secretary of Preparedness Response, CDC, Department of Defense, Health and Human Services. So these are all the folks that you have to interact with, and this whole list here, FDA, et cetera, on the government side. Here's the public trying to get information. Here, when you think about hospitals over here, acute care, Red Cross, disaster medical assistance teams, and then additional partners. You have you know, things like animal health, pharmacies, over-the-counter sales. So you have all these different information sources that you could be looking at. And then there are various much more, we don't have time for it here, much more looking at the workflow of each of these entities. And there's a whole listings of the information needs for each of those entities. And so just a final thing that really helped on this is that every student would then go in and they would post just maybe 2 or 3 paragraphs about what they thought. So, and then the students would comment on whether they liked each other's posts. So this student here, he said the author refers to biosurveillance as a process that necessitates more information than one system. This relates to a discussion of interoperability and data compatibility. Because of the biosurveillance initiative, we'll likely be collecting data from several sources. Due to that diagram I just showed you, reconciliation of the data becomes hugely salient. And conversely, a biosurveillance system will need to present outputs in a way that can be interpreted by the multiple stakeholders. And it goes on and on here. And so we get to see that this is the students' own words. And I think this is really important because we're looking at trying to educate people rapidly around these kinds of situations. How do you get something out there? You can't talk to people 3 hours about this. You can talk to them about 20 minutes, 10 minutes, and then the students each chime in on what they put in advance. Then they all talk about this for about 2 minutes.
And Richard, we're at a point where Nick's going to need to do some closing operations with this. I apologize. We didn't fully realize we were going to be in a situation. Can you sort of wrap up?
Sure. So I kind of think that just kind of wraps it up. That I know this was really quick, but the idea was to kind of take you through a quick tour of a system that gave access to information resources and student interaction, and basically turn it into a rapid education public health resource that you could use to share with your community healthcare workers, your public healthcare workers, that kind of thing. So that was really the overall gist of what we were trying to do. And just the only other thing I would say is, if I just go back here and do X, that what we were able to do is that summarize all that into a really, really wonderful ebook that we called RX Nudge, that actually had the students go through, do final projects on each of these areas, and each one of these little sections here is a whole little slide set and a paper that each student wrote as their final work around elderly care or CPO.
That's seriously cool.
So that's what we were able to do. So thank you very much, everybody.
Thank you, Richard. Nick, take it away.
Thank you. In the spirit of being expeditious, I would ask everybody to provide feedback by email, any way that you choose. We'll try and produce some output from this from a video standpoint. I am going to launch a poll because I want to get some quick feedback on something. I'm hoping this will show up. The question is, would you prefer this as it was with you as participants in audio, or would you like to participate with video? And to be clear, if you are on video, you can do what some people do, which is just have your picture or something like that. So you don't actually have to be on video as the panelists were. I think it's possible. I just want to get a quick sense of it. I know there's some learning points. I apologize to the people that I botched their names and some of the folks that didn't get on, but I thought we got into a reasonably good routine of people muting and controlling themselves so that I don't have to deal with that. And I hope it went reasonably well. It was certainly good from my perspective. I was looking at it to see how it sort of appeared on your viewers' side. Otherwise, my thanks to everybody for trying this and participating and sticking with it. I wish you all a a very sort of pleasant and happy sort of weekend through all of this. I am going to hang around for a little bit of time, but I do have something to get to. You can see it's behind me, so I'm going to be rushing off to that as soon as I possibly can. I certainly need it. I think we'll be doing this again just because of the way that things are. So thanks to everybody. I'll shut up and just say, formally we're closed, but I'm going to open it up and people can participate.